Hi, I'm Daniel Nyman. On behalf of the Forum for Healthcare Strategists, as well as our partners at Marketware, welcome and thank you for joining us for today's webinar. We're looking forward to a timely discussion on driving referral growth, pairing claims data with provider relations. Even in this new phase of the pandemic, provider relations is still one of the driving factors for growth. Today, you'll hear how pairing the efforts of your provider relations team with claims data can help your organization identify new patient opportunities and preserve your current referral relationships. One note before we begin. If you would like to ask a question, please enter it into the question and answer pane located on the bottom of the screen at any time. Our speakers will respond to as many questions as they can in the time we have. With that, I'll turn the program over to Josh Cameron, Vice President of Client Success for Marketware, who will be leading today's discussion. Josh?
Thank you, Daniel. I appreciate it. And thank you all for attending today's webinar. We're going to be covering a couple of different topics for today. We will be doing a couple more introductions to myself and Nancy here in a moment. We're really going to try and define what claims data is and maybe even what it's not. And then we'll talk about a couple of different examples, how Nancy and her team have been able to use claims data with their provider outreach team. A little bit about myself, as Daniel said, I am a vice president at the Marketware division of MedSphere. We offer a couple different products that I'll give a further explanation of here in a minute. But the real superstar of the show today is actually going to be Nancy. Nancy is the Senior Manager for Marketing Development at Children's Wisconsin. So Nancy, I'll turn it over to you to give a little bit of an introduction, not only to yourself, but your organization.
Sure. Thanks, Josh. Marketing development may be it's a new team to me. I'll talk a little bit about it as we get further on in the presentation of who my team consists of. But I am from Children's Wisconsin. We are located in Milwaukee. We are a freestanding children's hospital. You can see some of the stats here. And yeah, that's about what we had to say about Wisconsin.
Yeah.
I'm not in Wisconsin today, though. I'm live from Vegas.
Yeah, Nancy is graceful enough to join us even when she's not at home, which we appreciate. A little bit of an introduction to Marketware. So we offer a couple of different products to our clients. Our first key product is we have a physician relationship management tool. We kind of coined the phrase PRM. The more familiar phrase you might be with is CRM, but the reason why we call it physician relationship management system is really just kind of show that it's more geared towards physician relations, maybe rather than direct patient, direct to consumer relationships. We also have a healthcare analytics tool that houses the claims data that we'll be talking about today, and even some of our clients' EMR, EHR data as well. And then early last year, we also launched a provider recruitment and a provider onboarding tool. But to start with today's presentation, one of the key things I wanted to do up front was really kind of define what claims data is. I think it's a phrase that has become a lot more familiar with everyone over the last couple of years. But I think when it comes to maybe understanding, hey, well, what is claims data and what's it's not, there's still a little bit of a gray area for some people that I talk to. Really with claims data, we're trying to give you the full picture into your market. So, oftentimes health systems we're working with, children's hospitals, and even just individual specialty clinics, they maybe have a good insight of what's coming into their organization through their internal data. So they know on average, the number of procedures that they're doing for certain service lines. They have an idea of the number of new patient referrals that are coming in, and they may even have insight to where those referrals are coming, documenting their EMR. But what they don't always have the full scope of is what's going on in the rest of their market. While they know what they're doing internally, they might have good intuition of who their key competitors are, but they don't always know how they truly stack up against their competitors. Are their competitors far ahead of them, or maybe they far of their competitors, or is it even kind of a pretty even split with their competitors? And while they may know what's coming in with internal referrals, you don't always know, hey, are we getting 100% of those doctors' patients? Are they actually splitting between myself and a competitor? Claims data is really meant to kind of give that full picture. Now, For HIPAA and compliance reasons, we're not getting any patient identified information. We're not looking at the patient's name, their date of birth, any of those things that would be designated as PHI. We're not dealing with that data for just obvious compliance and HIPAA reasons. But we do have a couple of things that will give insight to a provider's patients. So the first things that claims data can kind of give insight into is from a procedure level, just understanding, hey, we want to be able to look at other, let's say, orthopedic surgeons in our market, and we want to know how many hip replacements, knee replacements, spine, hand, wrist, or elbow cases are they doing, so that we can kind of compare it to see what we're doing. They can also see the places of service they're doing that in. Is it inpatient, outpatient? Is it ASC? To kind of give an insight of where those type of procedures are primarily being performed. And it really allows them to kind of compare themselves with their internal data and those external providers as well. The claims data can also give insight into referral connections. So being able to see, hey, which doctors are referring the most patients and what service lines are they referring them to? So again, this is an orthopedics example. I can see the doctors that are referring the most patients to orthopedic surgeons, and then I can see which orthopedic surgeons are receiving the most patients. Again, I don't get any of that PHI information, but what we are doing with the claims data is we're giving every single patient a unique ID number, so that we can kind of see who are the different providers that that patient has had claims filed with, so that we get insight to referral connections. We also have some prescription data that can give us insight into patient origin. So again, due to HIPAA and PHI, I can't get the patient's actual home address, but what I can get is, where is that patient getting their prescription filled? Because more often than not, patients are getting prescriptions filled within about 5 miles of where they live. It's not perfect, you know, that you have some commuters that are maybe going in and out, but if you're trying to get an idea of, hey, where are patients primarily coming from and where are they primarily going to for certain service lines? Are they leaving my market to go to another market, or are they primarily staying in my market? You can get those type of insights. We also can look at a provider's payer mix to understand, you know, what percentage of their patients are commercial versus Medicare and Medicaid. And then we can even get some insights into the individual plans. Is it primarily United Healthcare, Blue Cross Blue Shield? And we can even see some of the third-party managed Medicare and Medicaid. And then the last example I give for claims data is we can see a provider's patient demographics. So we can see what percent of their patients are male versus female. So if you're doing like a urology campaign, or for those of you that are in adult care, if you're doing an OBGYN or women's wellness campaign, that can be helpful. Or for someone in Nancy's shoes that's working for a children's hospital, if you want to look at a list of family medicine doctors and figure out, hey, what percent of their patients are actually pediatric patients, so that you're kind of focusing on the right family medicine doctors and not the wrong family medicine doctors, that can be helpful. So that's just a quick overview of some of the capabilities that claims data can do. But the primary thing that we want to be walking through with today's presentation are some of the examples of how you can use your claims data with your provider relations and outreach programs. One of the first examples we're going to be looking at is just being able to focus on driving volume to either a particular service line or a particular market. Typically, one of the things that we'll see our clients do when they're typically focused on trying to drive volume is they'll go through a couple of steps. The first thing they'll do is they'll use the claims data to just figure out, let's say that we're looking at primary care and we're trying to see where they're sending their ENT patients. This is something that, you know, for children's hospitals like Nancy, they might primarily be focused in. The first thing we might look at is, hey, which providers just have the most patients? You know, that sometimes is the starting point. But then taking a step further, if you have a service line of interest, you know, just because they have the most patients might not mean that they have the most patients to the service line you care about. So then being able to kind of drill it down a little bit and say, hey, I want to figure out not only who has the most patients, but which doctor is actually sending the most patients to ENT or any other service line that you're interested in. Then you kind of analyze where are those providers primarily located at. Is it within your immediate primary service area, or is it maybe in some of those external markets that you want to look at doing marketing to? And then from there, you know, build an initiative and say, all right, we've got our list of doctors that we want to target, that we know are high volume referring doctors to ENT. Let's go out, let's visit those doctors. Let's kind of do our marketing push on why we bring value to those doctors. and then kind of use the internal data to track the immediate impact. With claims data, there does tend to be about a 3 to 5 month lag. So sometimes you're not always going to see those instant results in the claims data. Your internal data can kind of help you see those instant results right away. And then over time with the claims data, you can kind of see if there's truly shifts. Now, I want to take an opportunity to talk with Nancy about really how her organization approaches trying to drive volume, that acquisition patient model. Nancy, I've outlined a couple of steps here that we typically see our clients follow when they're trying to initially build an initiative and target growing a service line. Are you guys kind of following this exact model, or there maybe even some things that you guys are doing differently?
Mm-hmm. So we are using model very similar to this, which was really great when we did find our partner, our PRM partner, right? This was something new for us. So we needed to find that strategic partner that could help guide us and figure out how to use this data. You looking at this ENT example specifically, a couple of things just to highlight of points in the data that help us be a little bit more targeted on things. If we look at ENT, we'll look at our competitors in the community. Adult ENT doctors do see a fair amount of kids. And so remembering back a couple slides where Josh mentioned that you can break things down by age. So what is their age group of the patients that they're seeing? But then also you can look at procedures. And so we have been able to go in and look at tonsils and adenoids or ear tubes. So that way we can identify in the community as who's our biggest competition in the community. Then we sort of take a reverse look at that and see who is sending them the most patients. Who are the pediatricians in the community that are sending them the most patients? And what does that look different from what they're sending to Milwaukee? Go ahead.
Yeah, and this next slide, I think, kind of covers that a little bit too. So like one of the reports that we help our clients do, and I even kind of showed this in the previous slide, is the market integrity analysis. So this can allow you to kind of take your market, start with, okay, who are the primary initial referring providers? In this case, we're looking at pediatricians for Nancy's case. And then down there at the bottom right, we're trying to figure out, hey, who are the ENT doctors that are referring or receiving the most patients? And what's great about this one too is you can click on individual providers. So you can click on an individual primary care doctor and then see a list of, hey, these are the explicit ENT doctors that are receiving that doctor's patients, or the other way around. You can click an ENT doctor and figure out, where is it they're primarily getting their patients from? Candidly, a lot of our clients like to use this report to spy on their competitors. They'll immediately go look, hey, who's the primary competition that we have, and then figure out who are the providers that are primarily driving them volume. And then on the left side, it kind of gives you the insight into geography of, hey, where are these providers located? Both the initial providers and the secondary providers. And then what percent of doctors in those market are currently sending you patients versus not sending you patients? So a couple of questions for Nancy. When you're looking at a report like this, kind of two questions. One, what are the things that you're looking for to kind of go, hey, that's a target. That's someone that we need to be getting in front of. And then maybe on the flip side, what might be some of the things that you look for that might even say, hey, that doctor is not going to be a target. That's not going to be a good use of our time. What are some of the things that you're looking for in a report like this?
Yeah, so to highlight a couple of things here, we'll look at their network status, and we define network status probably not how anyone else does. We look at in network our own employed pediatricians. Our network friendly people are those that are on our medical staff. And then the out of network are people that are not on the medical staff. So that's one of the things we look at, because we don't put too much focus on our in-network providers, because they have access, they have easy access, convenient access to our specialists. The other thing that we'll look at is their affiliation. So we've done a lot of work. We do not take this data right from our Epic data because it was not clean. And so we are able to look by health system, by office, and location with some practice renaming work that we've done. And so we do look at that affiliation, because we know there's this health system locally that they typically just do not send us kiddos. They have insurance plans that they're not able to, their patients are not able to see us. And we'll also look at the geographic region where they're coming from, and what barriers they may be there to, whether it's just distance that isn't, we just don't have services in their areas. I don't think there's anything else.
Yeah, I mean, I think that one other thing is maybe when it comes to those key indicators, maybe like what not to target. So some of just to review, you might look at the affiliation, and if you see, hey, this doctor is already affiliated with another health system, you know, it's probably not fair to have an expectation that that doctor is going to start driving volume. But I also think from a geographic standpoint, you know, a lot of times people have good intuition, especially if they live in a major metropolitan of, hey, this is where primarily the patients are going to be. But once you get outside a major metropolitan, that's sometimes where you probably have some intuition of where the patients primarily are. But again, it's just intuition. So I think the claims data can kind of help value those kind of sub-markets to target which ones are the good opportunities, and even really which ones are not the good opportunities. You know, we always tell people with our claims data, you know, obviously our primary goal is to help you find opportunities, but I think sometimes the part that gets lost is sometimes trying to give you an insight of, hey, everyone has the intuition that there's an opportunity somewhere that there's not. You know, we've been able to help a lot of clients sometimes, you know, save major financial decisions by just realizing, hey, there's not the opportunity here that we thought that there was. This market maybe isn't as large, or there's not as many providers, or maybe it's too early. I think kind of be helpful too. Nancy, this particular report that I have pulled up here, this is looking at it by county, but I kind of want to ask how you guys look at things geographically, because there's a lot of ways you can look at it. Some people look by county, some look by city, some people even go down to the zip code level detail. They want to see where providers are and patients are in specific zips. Some people have predefined service areas, like this is my primary service area, secondary, tertiary. And then we've even seen some clients do more like a regional pod model. When you guys are analyzing the data, are you kind of looking at multiple of those examples that I just gave, or are you kind of geared more towards one or two?
Mm-hmm. Yeah, we most often look at county, especially in pediatrics. I don't know that you could really go much more. You can, zip code would be really hard, even as dense as Milwaukee is populated. The numbers just don't, you just can't really support it for pediatrics. So yeah, county, we do have two different sort of geographic regions set up where we have our liaisons, their territories set, but for the most part, we're definitely looking at county.
Yeah, okay. Kind of going into maybe the next slide. So I know that this presentation is primarily about pairing claims data with provider outreach. But I do think we need to acknowledge the other layer that goes with it, and that's your internal data. So one of the things that we try and help our clients do is being able to track their provider outreach, their internal data, and the claims data all in one platform. So while I know that the claims data is giving you and your organization, Nancy, a lot of value, how are you pairing that with the internal data and claims data? What are the benefits of maybe using both of those together to kind of drive some of the decisions you guys are making? And then look, I'll even be candid. What are some of the challenges of sometimes trying to align your internal data with claims data?
Mm-hmm. So the thing you didn't mention that we have three pieces of data in here too. So we finally have the full picture of everything. We have our internal data. So we do put our Epic data into the system. We have the claims data now, but then we also have our liaison activity. And that is so important. Every single activity is logged. All of those issues are logged. And so as we're looking at all of this data together, all of these pieces together, we're able to know, are there some issues? Are there some workflow issues? And maybe this is why we're not seeing some of the referrals that we should be. Are there competitors? We're looking at the claims data. Are there competitors out there in the community? And then to your question about claims data versus our internal data and the discrepancy, claims data is not 100% accurate. We go with about, in pediatrics, I put a number of 70% accurate in my head. And we are using it for tactical decisions in the field, in the moment decisions. We're not using that the data to drive big major strategies. We are not. And it's a guide. It's a guide for us. And don't look at the numbers. I don't look in claims data. I don't look at the volume numbers. I look at the percentages, because that gives us, it's a good gut check for us, right? It helps validate what we think we know, what our own data shows us, what our own Epic data shows us. And you mentioned earlier too, and if I'm jumping ahead, I apologize, but
You're
you
good.
talked about the delay, the lag, right?
Yeah.
We're used to hospital metrics, right? Where there was like 12, 18-month delay. So being able to get data that has 4 or 5 months, I mean, that's kind of it's really nice. Although we do pair that up, we really would not look at our claims data to measure our success. We would look at our own internal data for that. But
Yeah.
the delay is not that big of a deal, just a little plug there. It's actually really nice.
Yeah, well, that's good to hear. Quite a few questions have come through, and some of your questions I might say for the end, but just because there's a couple of questions I think that are maybe good to answer here with this particular use case. One of the questions that came in was, the dashboards look really good, but is there access more to granular data to see exactly what doctors are sending to which specialties? So the previous example I gave, I had just filtered this down from primary care to ENT, but I would say that you can look at multiple service lines at once. But this might be a good question for Nancy in a way, in that I know that our data gives you the ability to look at all service lines. I mean, you can look at PCP and see where they were referring for any service line. But when you guys initially are looking at, let's say, a key referring provider, do you instantly just start with, let's look at everything and everywhere that they're sending for every service line? Or do you guys normally come in with a kind of more targeted approach to say, all right, let's just start with ENT. And then from there, okay, let's then look at cardiology and then orthopedics. Or are you just kind of getting the full scope of it of, hey, we're about to meet with this provider tomorrow, let's just look at everything that they're sending?
Yeah, so we don't have an example of this, but we move out of this area of the PRM, of the dashboards, and we look at the individual profiles. So what's really nice about the tools, we can dig into Dr. Jones, and we can go out and look at their profile, where we can see, again, those 3 really important pieces of information. We can see their activity, how have the liaisons been able to visit with them, what issues have they had. We look at our internal data, so we can see what he sent to us. We can narrow it down by specialty if we want to, or we can look at the full picture. And then we can also look at the claims data. So on that individual provider basis, we can go and look at their profile and really get the full picture of the story there.
Yeah, that's good insight. I saw a couple of other questions come through, but I actually think that they might be tailored a little bit more towards our next use case. So we'll definitely get these answered, but I think our next use case might give some of the insight. So this first example we looked at was talking about driving new volume due to their service lines or geographic. But this next example we want to talk about is, you already know the volume, but it's not going to your organization like you'd like it would. So you want to potentially redirect some of that volume to your organization. So one of the things that we typically do with the claims data is, while we can look at multiple service lines at once, we tend to tell people getting started with the claims data to pick 2 to 3 service lines to start with. It's just a focus. So I know for a lot of people that they might say that that's cardiology, neurology, and orthopedics, tend to be the top 3 that we hear the most, but you could pick whatever you wanted. And then what we like to do is try and understand, hey, let's break this out by service line, because you might have a doctor that is referring you a significant amount of patients, but you really want to spread that out by service line. It's possible that they're sending you a lot of patients for cardiology, but when it comes to orthopedics, it's a different story. They're splitting it between you and a competitor, or maybe even with something like orthopedics, with Nancy, you being pediatrics, there might be some adult orthopedic providers that are maybe not pediatric orthopedic surgeons, but they will treat patients of a certain age, and maybe that's where some of their patients are going. And then really trying to use some of that data to drive some of the messaging there. So a couple of questions for Nancy. So one, as we're talking about service lines, one of the questions I had for you is, who in your organization is really determining what are the key service lines of interest? I know I said a moment ago, a lot of times like a cardiology, orthopedics, neurology are no-brainers, for any type of hospital or health system. But I would imagine as you go throughout the year and maybe you're hiring new physicians for a certain service line, you've opened a new facility, you just did a big CME event towards one service line. Who is it that's really determining, hey, for right now in this quarter or this time period of the year, we're really focusing on driving this service line? Is that a decision that the top of your leadership is making? Are you collaborating with other departments to make that decision? Like, who is it that are kind of the key stakeholders for that type of decision?
Sure. This has been really exciting work that we have been on a journey over the last couple of years. We did move from a traditional service line based marketing team structure to an acquisition and retention model, which has been really great. It's taken us a couple of years to get there. The other thing I'll note, which I'm very excited about, is just in this last year, we had been a physician relations referral development team and then a marketing services team. And so we were two separate teams. We worked really well together. But we were not fully aligned. And so with some staffing changes late last year, we were able to bring these two teams together under my leadership, which is very exciting for me. So the marketing planning, our physician relations space, we have aligned goals. We have we're working towards the same metrics. And again, for that acquisition and retention. And so how we identify, I want to say marketing sort of is the driver of who makes it to that acquisition and retention list. And it's not a static list. It is a list that can change throughout the year. There's some seasonality things when we think about fracture season, or we think about, when it's time for ear tubes and chronic sinusitis. So things can come on and come off, and how you sort of make it to the opportunity to be on that list. There's kind of three things we look at, right? We look at partners, our clinical partners who are set up to benefit most from our marketing support. So they're engaged with us. They understand what we can do for them, and they're primed to be good partners. And then they have opportunity for growth, the most growth for the organization. So what are their budgeted volumes? What does their access look like? Are they set up for success? Are their patient satisfaction scores? Are the families happy with them? And then the third thing we look at is that we have an opportunity to measure our success. So is there something that we can shoot for that we're looking at, whether it's looking at our own referral data, or something, narrow specific on a specific procedure, we want to increase some volume. So that's sort of how we identify with that. We do bring this, again, we have a really good relationship with our clinical partners, both the medical leader and the administrative leader for different areas. We'll be establishing this year some sort of rounding with them. So I'm meeting with a lot of people once or twice a year. Instead of waiting for them to come to us, we want to get to a place where we're more proactive with things. So again, and then we bring this to our VP group. So our senior leaders in the organization, we kind of bring to them and say, these are our areas on the list. We want to put our priorities where we think we can move the needle the most. They validate it, push back, offer up other suggestions. So it's a great partnership with our operational colleagues.
And I think that you guys do that better than most. One of the things that's interesting about being in the role that I'm in, so we work with I think we're at about 130, 140 clients total of all shapes and size, hospitals, health systems, pediatric, single specialty clinics. And I think one of the things I'm always surprised by is, a lot of organizations have a marketing department, an outreach department, a strategy and business development department, and rarely are those aligned. I've been in situations where the people in the marketing department and the strategy and business department don't know each other. We at Marketware are leading some of those introductions sometimes to each other. And I think that's one of the things that you guys have done really, really well. And I think that's a key takeaway here, being able to cross collaborate. I'll jump in more to the specific example that we want to look at, but then I have a couple of questions, and then I've seen a couple of questions come through that I think are going to be good to answer here. So this example right here is looking at just 3 different pediatricians, and we're breaking the loyalty out by 3 service lines that we've selected. cardiology, orthopedics, and ENT. I know that one of the questions that kind of came through here in a moment was not only being able to look at by specific specialties, but can you look at it geographically too? That's one of the other helpful parts about this is you can take a particular market, whether you want to look at it by county and service area, and then you can say, hey, when it comes to cardiology, how many of our doctors are strong versus reliable or weak? Or when it comes to orthopedics, or they splitters, whatever it may be. But to break this down a little bit further, we use 4 different categories. And you can come up with your own custom, and you can even change some of the percentages on it. But our standard is, we would say that if they're giving you more than 75% of their patients, there's a strong connection there. You can look at it overall for all service lines, or you can break it out like we did here. Then what we say is, hey, if they're giving you the majority of their patients, so more than 50%, that maybe they don't cross that 75% threshold, we consider them reliable. They're giving you the majority, but maybe the relationship isn't as strong as you'd like it to be. And then we have that splitter category. They are indeed giving you some patients, but it's not a majority of their patients. It's somewhere between 26 and 50%. And then lastly, we have weak, which is just, it's less than 25%, or maybe it's even non-existent. So I took an example here. You might see that there's a provider, we'll take that first doctor there, Dr. Willis. We can see for cardiology, strong, 77%. Orthopedics, it's more of a splitter, 41%. And then ENT, it kind of falls more in that reliable bucket. So I've got a couple questions here that I want to break down for Nancy. So one, and this is actually, I think, one of the ones that came through the chat. Obviously one of the key ways that you want to use this data, Nancy, is to figure out who are those splitters that we know we're getting some patients from, but we want to grow those relationships. But I think a practical question that came through the chat even was, okay, let's say that you've identified a splitter. All right, you've got a doctor that you now see, all right, they're only giving me 40% of their patients. We're getting some, but we think we should get more. How do you approach that conversation? Because I think the last thing you want to do sometimes is go stick this data in the doctor's face and say, maybe this doctor has been telling you, and I think this got mentioned in the chat, they're telling you, oh, we're strong, we're giving you all of our orthopedics business. But then you peel back the layers a little bit and you kind of realize, oh yeah, they're not giving us all the orthopedic patients. Like, how do you engage a provider with that conversation without it coming across as you're not giving me enough, essentially? How are you having that type of conversation?
Yeah. And that's probably a hard question for me to answer, harder for me to answer. I've not ever been a liaison. So I've not walked in those shoes to have these conversations. But before we even get to that conversation, we're still looking at the data a little bit deeper, right? Are there, for this last one on your list, we're not getting the orthopedics. Do they have something right in their own building where there's access to? Again, for pediatrics, is there a pediatric orthopedic in their health system that they are supposed to refer to, right? They're encouraged to refer to. So again, going back and looking at that data a little bit to try to tell us the full picture before we go in and have those conversations. Yeah. And then, again, not a liaison, haven't been in those shoes, but working on that relationship and being able to have those conversations a little transparent. You're not going to serve up the data and be like, well, I know you're not sending us all of our patients. But I think it's an opportunity, again, to work with our clinical colleagues and our marketing colleagues of switching up those messages. What are they sending us? Is it a particular diagnosis? Is it procedure that they're sending us? And to be able to, again, use the data to help us craft the story and craft our plan.
Yeah, I think we have a good point there. I think oftentimes people see that splitter category or that weak category, and they immediately want to hit the panic button, or they immediately just want to run to the doctor's office. But I think, like you said, the value is with this data, okay, you can figure out who is that, 60% or 59% that is getting, who is it that's getting the patients, and then figure out, oh, that's a doctor that, you're right, is in the same building. That doctor is geographically closer. Mm-hmm. But I also think it can lead to conversations with the provider. I don't think it's ever good to go stick this data in a doctor's face, but I do think that when you approach a doctor, you can kind of say, hey, look, I'm not naive. I realize that we're not getting 100% of your patients. We understand that. So ask the doctor, hey, what is it that's preventing you? We know that you send us some patients, but what prevents you from sending us some patients? And what you might find is, oh, it's a payer issue. You know, there's a particular plan that your organization's not working with that your competitor is. It could be a geographic issue. It could be, hey, there's an orthopedic surgeon literally in my building, and it just, it makes more sense. It could be patient choice even. It could be that, hey, this is where the patients want to go. It also could even be that that doctor's just good, that pediatrician's just good friends with that orthopedic surgeon. And that's just not going to change. There's no marketing effort you can do, but it's still, I think, knowing that narrative and document it and just realizing, okay, this is one of those not opportunities, or maybe you do uncover an insight that, oh, this is an insight. I've even seen situations with liaisons that I've worked with that sometimes the doctor actually genuinely doesn't know that there's this big of a split. It could be that, they have nurse practitioners in their office or referral coordinator that's directing patient. Like sometimes the doctor's assuming that the majority of the patients are going to you and they're not. And so sometimes it just kind of leads to an educational decision. Couple of other follow-up questions though, just for this particular use case.
Just before you move on though, Jess, I want to highlight again here too. Claims data, we do not look at claims data to give us answers. What claims data does, it gives us more questions to ask, right? And again, we have to reflect back and again, with orthopedics, all of those other things you mentioned, we may also have like a 6-week wait time. So again, we're going to ask more questions and not, if claims data is not there to give us the answer. That is not what our intent of using it is.
Mm-hmm. Do you also, and I think this might touch on a question that someone had in the chat. I'm sure there's got to be instances where, internally there's a consensus, let's say Dr. Willis, there could be an internal consensus that says, oh yeah, we've got a great relationship with him, everything's good. You start to pull back the data and kind of go, and let's say that you really do all the digging and you find out, hey, it really doesn't look like this relationship is strong. You have a discrepancy between what you guys think internally, what the data is showing, and what's your internal data. Like, how do you approach that conversation internally? Are you bringing that up when you're talking with other departments? Or are you presenting it as, hey, look, the claims data says this, so it can't be this? Or are you presenting it more of, hey, look, there might just be something to explore here. We're not guaranteeing one thing or the other, but look, we have a data point that is saying it's not as strong. We need to go figure it out. Like, how do you approach that even internally?
Yeah, so we're pretty thoughtful about how we're sharing claims data with our clinical colleagues, because it is, again, I go back to that 70% accurate. It is a guide. It is not, the end all be all of everything. So we're really thoughtful when we do talk about claims data and when we have access to, and we have not yet, knock on wood, really dug into anything where we're seeing what our perception or what the thought is from our clinical colleagues about relationship and whatnot, and that referrals or that claims data looks that much different. But again, we're only a year into our journey with claims data. So that will be something that I'm sure will come to us as we start to dig deeper into things.
Yeah. And then you guys are using our PRM as well. So when it comes to like a documentation standpoint, we see clients do a lot of different things. Some clients, I think, can maybe over document things. I think that they can get into the weeds of logging their activities, that they're writing like 2 or 3 paragraphs of what happened in a visit. We have other clients that I think candidly maybe don't put enough insight. It's just, I visited this provider and that's the insight. So like, what are some of the key things, if we go back to that last report for a second, let's say that you've identified a list of splitters for a particular service line. You're wanting to do outreach and you're collaborating with marketing on messaging you're wanting to give to those doctors. When your liaison team is logging those visits in the PRM, what are the expectations that you're giving them of, hey, these are the data points that I want to be able to see in the PRM and what's coming out of those conversations with those potential splitters?
Yeah, the most important thing that we have implemented in with the PRM, the login in the PRM, is consistency. We have the every activity is logged with the liaisons, everything that they're doing, emails that they're sending out, visits that they're doing, all of that sort of thing. And we've really limited the categories of how we can log things. And we have a crosswalk, so we know as if someone, we select a category, we have a definition for that too. So we are just consistent in logging things because that helps our reporting too. Being able to log things if they're a acquisition, a category that we're going after to acquire new patients for this particular specialty. Are we looking to retain those types of things? But most important is this consistency. I know our liaisons at the beginning of this were like, oh my gosh, because we would go back and have to fix some things because they were not maybe being logged correctly. And quickly we see the benefit of it in our own reporting out of things.
And then how often do you, like, as a manager, how often are you, obviously your team's logging everything. As a manager, how often are you looking at it? I see some clients that, they're looking at it as much as daily or weekly. Some are looking at monthly, some are looking at quarterly. Like, do you have some type of routine cadence, or is it more just an as needed basis?
Yeah, it's more as needed. We have a really great team, a really super high functioning team, high accountability. This is their tool. This is their tool to do their job better out in the field. It's not out there for me to make sure that they're hitting their visits for the week and that sort of thing.
Yeah.
They're doing all of that. So
your team doesn't have, like, because I know a lot of teams, and it's a more older traditional model, there's like a quota model. You got to visit X amount of providers per week, per month, per quarter.
Nope.
Do you guys have any of those metrics in place, or is it more like you said, we know what we're doing strategy wise, and you have that trust in your team?
Yeah, we really don't. Again, you hire the people that you trust that are out there. They would set higher standards than I probably ever would for them. I think when you have someone new joining the team, it's a good thing to shoot for because it kind of sets the pace for them as they're getting used to their territory. But we don't. Again, the activity tracking is to the liaison's benefit. We have a couple different places in there that we can put some notes. There's more of a detailed description and then some high level things that only they see. We're working towards sharing some of, especially on some of the issue resolution things, sharing some of that with our leadership. We're also working this year on with our clinical colleagues, sharing some of our activity volumes with our clinical colleagues too. It's important for them to see that we are out in the field. We are talking about their service area. Well, and we started something. There was a little area in Marketware that it's a star. There was 5 stars, and we weren't really sure how to use that. And it's one of the things that we put into place just this last year, where every activity is given a rating from like a 1 star to a 5 star. 1 star would be a one-way email we send out to someone, but then you could have an email where you're actually engaging with someone, and it'd be a 4 star. So we're on this journey right now of being able to share back with our clinical colleagues our level of effort or our impact in the field. I don't know that we'll ever share visit numbers because what's good?
It kind of leads to a lot of unnecessary
good,
scrutiny,
right?
sometimes.
Right. And
then there's questions like, well, how many did cardiology get? We're orthopedics, we should get more. And that kind of leads, I'll break this question up. So someone had just put in the chat, do your service lines know who some of their top referring providers are? And what is your role in identifying those referring providers? Like, I think that's actually a really, really good question, because like I said, I think a lot of times there's internal consensus or intuition of who the top referring providers are. But again, it's not always people are looking at a data report in front of them that says this is who legitimately your top referring providers are. So when it comes to those service line leaders, that you're letting them know, hey, these are the providers that we're marketing your service line on your behalf for. So like going to orthopedics and, hey, here's all the doctors we're talking about orthopedics with, here's the potential impact of it. and then, hey, here's who the top referring doctors are to orthopedics. Are they getting that type of report already from a different department within your organization, or are you guys the ones going, hey, orthopedics, this is who your top referring providers are? Like, you guys are the one kind of driving that information.
So we're not in our journey yet where we're sharing that level of information with them yet, right? So again, we've been doing this, we're at this for a year. We're not there. Are they looking at it from their own data? I don't know, to be honest with you. We know the physicians are not. I mean, they're not. They're and their administrators and whatnot. Again, our Epic data isn't that clean. You can look at the individual physicians referring data in, but to look at it by health system or practice is really difficult because the name, they're not nothing. No, two doctors may have different names for their practice location and they're working out of the same building. So it's not really clean for them in our internal data to be able to look at that. Do I think we'll get there in the future? Sure.
Yeah.
But again, what's the value? Why would we put effort in our clinical colleagues knowing that these are our top incoming referring physicians? What are we going to get out of that? How is that going to help us acquire more patients? Where we have, I guess I should pause, where we have looked at that is in an area where we had some people leave. And so we were looking at a 4 or 5 month wait for patients.
When you said people, like you had physicians leave. Okay.
We had physicians leave. And so we did look at who are our top incoming referring physicians, who are sending us the most patients, because that was an opportunity for us to focus and preserve that relationship, give them the heads up, say, hey, we have some things happening. We have some people that have left. Be patient with us. Please let us know if there's issues that are coming in. So I guess looking at things that way, that's where that can be a benefit.
Yeah. And I'll give you the flip side of that too, is you hear that one of your competitors has a doctor retiring or a doctor leaving, being able to go use the claims data and then figure out, hey, who is it that's primarily driving them patients? And are those doctors that I should go have a conversation with to see if there's an opportunity to kind of redirect business? Only final question I have, I think, on this use case was, so if you see this example here, all right, you have providers that are splitting patients with orthopedics. Is there a point in which you get your orthopedic surgeons involved with your outreach? Like, could there come a point where you're telling, again, I know that you want to be careful sometimes about putting this type of data in front of a doctor, because, just some of the questions and scrutiny that comes with it. But, if you find a situation where it's like, man, I really think bringing out my orthopedic surgeon to meet this doctor and try and strengthen that relationship, what are the indicators maybe for you guys that says, all right, this is an opportunity where we probably should get our doctor involved with the outreach?
Again, this is a starting point of looking at the category here of and again, want more questions to ask. Is there opportunity for us to increase the volume and acquire new patients?
Yeah, because sometimes it's better for the doctor to be the one asking those questions than your liaison. Sometimes they can kind of peel that back a little bit better.
Yeah, and then how do we do that, right? Do we put them in front of a CME and give a lecture that way? Do we actually try to take them on either in-person or virtual visits? But be able to find the strategy that can work best there.
Yeah. Okay. All right. Well, I know that I want to be respectful of everybody's time, so we'll go and jump into our third example. The first is talking about retaining volume. So this kind of goes into that acquisition retention model that you talked about earlier, and that, obviously you guys are always looking to, grow and drive new opportunities. But you're also looking to, hey, let's maintain what we have. Let's keep those referral pipelines that we have. So we've already talked about a couple of ways. You can be looking at your internal data to show you, hey, this is who's primarily driving patients to your organization. You can also kind of maybe use the claims data to kind of affirm that, to go, all right, this relationship really is strong. The utilization is there. But maybe what are some of the things that, when it comes to those providers that fall in that strong category, that there's strong relationships there. What are maybe some of the things that you and your organization are offering them that maybe sets them apart from some of those other doctors that the relationship isn't strong?
So we have a group in both our Metro Milwaukee and in Northeast Wisconsin. It's a community physician advisory group. It's been established. I mean, the one in Milwaukee, we probably started 15, maybe 17 years ago. And it is made up of community physicians who are very active, high referrers into the system. They know us well. And their feedback is so incredibly valuable. We meet with them it's either 3 or 4 times a year. So being able to identify those really, really loyal pediatricians in the community, bringing them inside the walls. We're showing them our dirty laundry, right? There may be workflows that aren't working really well. We have some barriers for some areas. We also, it's an opportunity for us to kind of highlight new providers coming in, new programs that are available and out there. They get a little extra first look at some of the information, but we get so much more back from them. Again, where there's issues that we would have never seen. I had a leader once say that it was a great opportunity because they would tell you when there was spinach in your teeth, when you didn't know that anything was going wrong. They're not afraid because, and why they continue to come back time after time. People have sat on this for years, on this group for years, because we actually make a change, right? And we're able to come back to them and show them, yes, we are listening, and we've been able to make some of that change.
Yeah, and I think doctors appreciate that transparency. You know, if you're going to have something like you have a doctor that's on maternity leave, and you know that, you know, scheduling is going to be backed up a little bit. I think being upfront with providers and even their office staff about that type of thing, I think that they appreciate that. I don't think what doctors like is being in the blind and all of a sudden scheduling's back up. They will quickly pivot to one of your competitors if they haven't got that type of communication. So being upfront with them, that's helpful.
Yeah, our failure in us not being able to get their patients in or in an effective or an efficient way, it's their failure. It turns into their failure.
Yeah.
And they will seek the path of least resistance.
Yeah, that's understandable. Now, when we talk about doctors that you consider in that retain model, hey, these are doctors that we're wanting to keep these referral pipelines strong because it's they're sending us a lot of patients. There's really a couple different ways you can measure that. You know, you could look at it, and this is a report we have in Marketware. You could look at it by just going, hey, who's just sending the most patients? We just want to look at patient volume, and that's it. And that's who we consider the top referring doctors. But then there's other metrics you might look at too. You might want to break it down by service line. Like, hey, are they actually sending us patients to the service lines that, you know, are most beneficial to our organization? You might look at it by revenue. To just say, hey, you know, just because they're sending the most volume doesn't always mean they're sending the most revenue. And there's a lot of different things that you could look at. Maybe it's even payer mix. You know, hey, they're giving us a lot of patients, but it's primarily Medicaid plans, the pediatric Medicaid plans. You might want to focus more on commercial. So I'm sure it's maybe a combination of everything that I just said, but when you're really kind of defining, hey, these are our top referring providers, what are the primary things that your organization looks at to consider those doctors in that strong relationship?
So you're right. You look at several different things, not looking at pure volumes alone either, because it could be a practice that is close proximity to one of our locations. They might have a really high Medicaid patient panel, and we are the option for them to send their patients to us. So looking at some of the volume, but then being able to dig down and look at how does that compare across all of the specialties that they're referring to us. Geographically, do we have a facility close to them? Is it easily accessible? And then if we really want to dig deeper again, looking at what their payer mix looks like. They may have kiddos in their payer mix in their plans that we just are not in their plans. Children's is not in their top tier for plans, and they're not able to send us patients. So again, being able to look at that and identify where we should be putting our, not necessarily where only where we put our focus, but what is that message we're going into those offices with too? We're going to go into an office that is high Medicaid, high volume. We're going to go into a different, with a different message there than we are of someone else who might be high volume, but there might be some shifts between the specialties there.
Yeah. Okay. And then our last slide before we try and answer a couple of questions is a claims data report that can kind of affirm, looking at a high level, let's just affirm, like we talked about earlier, hey, these are the doctors that are truly are strong, percentage wise. You can break it down by service area, you can break it down by specialty. But the final question I had for you, Nancy, is, I know that a lot of physician outreach teams are typically responsible for doing outreach to external doctors outside your organization, or maybe doctors that are on your med staff, but again, they're not those employed doctors. That's typically primarily who outreach is targeting. But you guys being a children's hospital, and a lot of our clients, maybe people on the calls today, they have their own employed primary care doctors. So I wanted to understand, does your team have any responsibility with those internal doctors? And I know that you're maybe not marketing to your internal doctors because they're internal, but like in a way, you may. So you want to make sure that that your internal employed primary care doctors have the right messages and know where they're sending the patients. Does your team play a role in working with your employed primary care doctors at all, or are you guys just external only?
Yep. So up until, I guess now, we've been focused on external, but with us bringing in the marketing team together with that physician relations team together, and thinking about, as we're one big practice, we're primary care and we're specialty care working together. We're on this journey. We're kicking it off, meeting with the medical directors for our primary care to identify what is their greatest need. Their needs are not the same as they are for the referring physician out in the community. And we shouldn't necessarily think of them as a referring physician. They are our colleagues, right? They are in our system. And so their needs are going to be very different. So we're going to spend the rest of this year sort of evaluating what those needs are. We don't look at leakage. We probably will not look at leakage, looking at specific numbers.
That was going to be my next question, because one of the primary reasons that people tend to purchase Marketware is they're trying to figure out, are their internal doctors truly keeping everything internal? That's one of the primary use cases we tend to get right away. But I think you guys are a little bit unique. And I don't know if this is just with the way your organization is, or even it's the fact that candidly you're a children's hospital and you function a little bit differently. That's what I was going to ask is, would you guys look at leakage? It sounds like you're already saying no to that. Or if you were to uncover, hey, I've got an in-network doctor that's splitting for whatever reason, is that something that your team would help facilitate the discussion with, or is that just more passing that off to someone else in leadership?
Yeah, we would work with our colleagues, our primary care colleagues, to address that. We would not have that conversation individually with those physicians or whatnot. Okay. I think what this could help us, though, potentially looking at some of our own referral data, again, us being matched up with our marketing team. Is it patient preference?
Yeah.
Right. There could be some patient preference thing that we could adapt and shift our consumer marketing to make a shift there. There also could be some internal workflow that might be broken as well that could help us identify, but not getting down to the individual physicians with a service line. No.
Okay. Right.
I don't think it builds trust and confidence with our teams, right?
Yeah. I think that's really good. Well, we've got just a small couple of minutes left, so I want to make sure that I tried to have us make sure that we answered some of the questions as we come and go, but I think that there were a couple that we maybe didn't touch on. There were a lot of questions around, I think, data capture and the number of claims that we're giving. So I'll give kind of the Marketware answer on this. And then Nancy, I definitely want you to give your insight. Our national average of the number of claims that we're getting for providers is around 80%. It does vary by market. There's some states that's closer to 90%. There's some states that's a little bit less, closer to 70%. But I know that there was a question specifically on pediatrics. Obviously, there's some nuance with the pediatric claims. Nancy kind of already alluded to this earlier. I would say that the average with pediatrics tends to be closer to about 70% of claims that we're seeing. We technically are getting all payers. So that's going to be both the commercial plans and then even the Medicaid plans as well for pediatrics. In terms of maybe why we're not getting 100%, it tends to be because the provider is submitting their claims to a clearinghouse that we're not currently partnered with. These tend to be independent doctors that are working with a less known clearinghouse to where we're not always seeing some of the claims, but there's always certain nuances with certain maybe payers. So that's kind of the standard Marketware, but Nancy, I know that you've kind of already alluded to it some earlier, so I want to give you an opportunity to give your insight too.
Again, we go in with the assumption of about 70%. It's a guide. It's a guide for us. We do not look at specific volume numbers. I look at percentages, look at the little color bars and kind of see, oh, that's about right. That's not, and again, claims data is just one piece of the puzzle, right? We're using it to supplement our own internal data and our activity data out in the field. It's not the only piece of information that we're looking at. It's just one piece.
Okay. And then a couple of other quick questions. I think they'll be quick answers. One of the questions, I think I can take this one, was just how often is the claims data updated? We already mentioned there's about a 3 to 5 month lag depending on where you're at, but we update it on a quarterly basis. So at the beginning of the quarter, it'll be like 3 months outdated. Then at the end of the quarter, it'll be closer to 5 to 6 months outdated, but we update it on a quarterly basis. Another question that Nancy, this can be our final one, and I think we can tag team it, is there are a couple of questions about like, how are you getting a list of all the providers in your market? So it's actually a couple layers. So we, as a claims vendor, we partner with the American Medical Association. So we can take a state like Wisconsin and we can say, all right, give us a list of all the providers in Wisconsin, what's their MPI, what's their name, what's their specialty, where do they practice, and what's their address. And that is the starting point for most of our clients. And AMA tends to be pretty close in terms of accuracy, but it's not 100%. I won't pretend, especially if I have a doctor that just in the last 2 or 3 months has switched practices. AMA doesn't always catch that right away. So we give our clients the ability to, one, the liaisons change demographics themselves, and then we won't override them. Or two, you may have and this is where I'll chime over to Nancy. Some of our clients have their own internal demographics from their EMR. But Nancy, I'll let you kind of close that answer out.
Yeah, so we supplemented with that, right? So we start with our own internal data, our Epic data, our credentialing data. So those people that are on our medical staff, again, with our Epic data, with our liaisons, do a lot of really great cleanup work in the data. And then we supplemented that with the claims data, knowing we sort of had that hierarchy set of what we know is true. And then we get a little less accurate from there. But again, we have the opportunity to go in and change it and override it. So, so we can get more accurate.
Yeah, that's great. And then one other quick one I came through, and this will be the last one, is does claims data include inpatient and outpatient? Yes, includes inpatient, outpatient, office setting, ASC, urgent care, and we've even started including telemedicine as well. But I'll turn it over to Daniel to kind of close things out. Thank you all so much for your time today. I hope that this was insightful for all of you. Feel free to reach out to me at any point, and then feel free to reach out to Nancy as well. But Daniel, I'll turn it over to you.
Thank you, Nancy and Josh, for that terrific presentation. I'm sure the audience joins me in thanking you as well. And to all of you in our audience, thank you for taking the time to join us today. Please note that if you asked a question that we weren't able to get to, we'll do our best to get a response to you. We'll also be sending out a link to the webinar recording, so watch for that within the next few days. That concludes today's program. We hope to see you at a future forum webinar, as well as the Healthcare Marketing and Physician Strategy Summit, May 16th to 18th in Salt Lake City. Please visit the forum website at healthcarestrategy.com to learn more and to register. Finally, be sure to give us your feedback by completing the evaluation survey as you exit the webinar. Thank you.